Thanks everyone. I'm very impressed at you all being here so early for a conference breakfast. I think in the bio, extensive experience just means that you've been around a very long time. It's just a nicer way of saying it. Thanks for joining us this morning. We are talking about managing chronic wounds, and probably not the most appetising breakfast topic, but I promise you I'm a dietitian, not a nurse. Therefore, there are very few wound photos in my presentation, okay? Yeah, I know, disappointment, sorry. Wounds, the actual looking at wounds is not a passion of mine. So, to get us started, just disclosures, I am Medical Affairs Manager at Nestle Health Science, and we do sell some oral nutrition supplements specifically designed for wound care. But I would also like to disclose that fortunately at the moment I'm currently unaffected by a chronic wound, so I speak from no personal experience here whatsoever. So, chronic wounds. I guess because you're here, you see quite a lot of chronic wounds in your practice, so you're involved in that quite a lot. And what sort of demographics of the patients that you're managing wounds? Younger, older? Older. That's an immense relief to me because my interest area is older nutrition for older people. And so I am focusing a bit on what you can do for that demographic and that population more specifically than younger, but of course it affects all age ranges. So I'll just spend a bit of time this morning having a look at the problem of chronic wounds, what we know about the numbers, the nutritional needs as they relate to an older population, and just try and highlight why it's so crucial for older people to take a bit more care of their nutrition for both prevention and healing of wounds. Then look at nutrition as it relates to wound healing, some of the key nutrients, and spend a little bit of time looking at arginine. And then see if there's just what are the sort of steps that you can take to improve the nutrition for the patients that you see. So, if we look at the numbers, the numbers here that relate to chronic wounds, 400,000 people affected, that's actually talking about institutional settings. So you're looking at residential care, hospital care, rather than community. There's very, very little data about the prevalence of chronic wounds in the community. And it's often because it's not the primary reason for the consult. So it's a consequence of diabetes or some other health condition. So even when you look at GP data, and they used to collect data, stop now, but and publish GP consultations, practice nurse consultations, wounds are rarely there. There might be some skin integrity issues, there might be, it really doesn't get covered. It's all, there's obesity, there's diabetes, there's neurological conditions, there's vascular conditions, but wounds itself doesn't get identified. So it's actually quite hard to know what the prevalence is. In institutional settings, pressure injuries are the most common type of chronic wound, but in primary care, it's probably venous leg ulcers and diabetic foot ulcers that are more common. Would that be your experience, that you would see that sort of chronic wound? And when we're talking chronic, we're talking about a wound that hasn't healed for 4 weeks, so you're still trying to get it to heal after 4 weeks. But the prevalence is going to increase because we've got the ageing population, we've got diabetes on the rise, and we've got obesity on the rise. And those three things together are going to see an increase in chronic wounds. And of course, they have a massive impact on quality of life, on cost, and a lot of the costs are borne by the patient themselves associated with wound care. So they really have an amazing impact. If we try and work out numbers in the community, there was a study back, it was published in 2005, so it's quite old, but they just were in a district nursing service in New South Wales, and they reported that 57% of the referrals of their nursing service were because of wound management. So we know it's common, we just don't quite know how common. All right, so if you indulge me and let me talk about nutrition in an ageing population. When you see older patients, continue to come in, find a seat, don't worry about disrupt, there's some up here. Do you get much of a chance to talk to older patients about nutrition issues? A lot. Perfect, good. And is it sort of on a casual, like it tends to come up in conversation type thing, or do you ask them specifically about it? Ask them?
Yes.
Yep, great. So what happens with nutrition and ageing is that as we get older, our calorie energy requirements reduce, and that stands to reason. You have a lower body mass, muscle mass as you get older, and you have less physical activity as you get older, so you don't need as many calories. The problem is, though, that your requirements for nutrients actually increases. So you have a much higher requirement for protein, you have a much higher requirement for calcium, vitamin D, some of the B group vitamins, possibly zinc. So the quality of the diet becomes really, really very important because you don't need as many calories. So people don't actually need to consume as many calories, but they need those calories to be providing all those nutrients. And so in older adults, 25% higher requirement for protein than younger adults. So younger adults, we would require, I'm saying we, but anyway, younger is like less than 70, so I'm okay, is about 0.75 grams per kilo to 0.8 grams per kilo. Older adults, it goes up to 1, or it's suggested now 1.2 grams per kilo. So going from 0.75 grams per kilo up to 1.2 grams per kilo. But that, of course, comes in the context of dietary changes which are brought about by people eating less, they're drinking less, so the cues for thirst are less, eating at a slower rate, feeling full earlier. And so there's a syndrome called the anorexia of aging, which is a physiological syndrome where so your hormones change so that after a small amount of food you feel full, and less snacking. And then, as you'd be well aware, you have all these social and lifestyle changes. So you have people who might have been always in a family environment of eating are on their own. In women, actually, the research is quite interesting that sometimes women's diets improve because they're not catering for someone else all the time. So they're actually doing foods that they like and they enjoy. And then if in the demographics now, and I'm sure this will change, but often men are left without a partner and limited in their cooking capacity, and smaller portions, but also, getting out to go to the shops, getting food, loneliness, so many social factors that impact food intake. And this all leads to a greater risk of malnutrition, and I think traditionally we've thought of malnutrition as someone really skinny. That's kind of our definition, and that's how we identify someone who's at nutritional risk, but that's not the case. You don't need to be skinny to be malnourished. And in older people, that sort of where skinny is a health hazard is probably at a higher BMI than young people. So we've done some studies looking at the literature, and mortality risk is actually lower for older people when they're in the BMI of sort of 26 to 28 range rather than 20 to 25 as in younger adults. And as we get older, we also, unfortunately, and it is a fact of life, our muscle mass declines as we get older and fat mass increases. So if your weight's stable, you'll still have a shift between fat and muscle. That sucks, yes, that's just not fair, but you can attenuate that loss by having a really good protein intake. So if we look at people over a period of time, those older people that have a greater loss of muscle mass are the ones that eat a lot less protein. And if weight loss is also a problem, unintentional and intentional, we have to be very careful, and often older women are still trying to lose weight, and they're still conscious of clothes, and my mother's 88 and she's still talking about, I went there and she'd tried one of the meal replacements for weight loss, and just because you don't change just because you're getting older, so they potentially are still trying to cut calories, and any weight loss will result in muscle loss, and so this is where activity comes into it. You really need to make sure older people are as active as possible. So the changes in nutrient intake, so I was saying that we need less calories, and this is the Australian data from the health survey back in 2011, 2012. And you can see that as people get older, they do actually reduce their calorie intake, and you see a significant reduction in protein intake. So younger adults eat masses of protein. So the high protein fat at the moment is really a bit unnecessary, because generally the younger population, and I'm talking really anybody under 60, eats way more protein than we actually need physiologically. But you do see this reduction, and this is a healthy population, so we're not looking at the really frail elderly, we're looking as just a natural consequence, people reduce their protein intake. And this is manifest as malnutrition in older people. So data using the mini nutritional assessment to screen older adults for nutritional risk finds that a third of them are at risk of malnutrition. And that risk of malnutrition, even if you're not frankly malnourished, that's associated with greater risk of hospitalisation, loss of independence, succumbing to infections, taking longer to recover from infections, and obviously it's going to result in poor wound healing. So this means if you put together the 32% at risk of malnutrition, the 6% who are malnourished, you've got nearly 40% of older people who are at nutritional risk. So that's 4 in 10 of the patients that are coming in to your clinics are malnourished or at risk of malnutrition. So why is it important? Well, when you have a wound, you have this tsunami of physiological processes going on that need extra nutrients. So you have so much. Your body, if there's a wound, it has to mount an immune response. It has to clean the wound. So you have exudate. And that exudate that leaks out from a wound is really protein rich. So anybody who's losing a lot of fluid from their wound is losing protein in that fluid, and that's got to be replaced by their diet. And if it's not replaced by their diet, then they're going to start breaking down their own muscles to make up for that protein. Because of course, when you've got a wound, you also need to synthesize tissue, you need cell proliferation. For all that healing, you need new cells and new tissue, and that requires nutrients. And I think it's so obvious that you can't heal a wound without good nutrition. So obvious, but it's just that when you're faced with a wound that's not healing, there's so many other things to consider. There's, what dressings are you going to use? What medications are they on? Are they mobile? Do you need pressure relieving devices? There's just so much else to consider, it can get forgotten. So you can see dietitians, we have nice pictures of food rather than nasty pictures of wounds. Optimising nutritional is absolutely essential, and if you don't have adequate nutrition, you are not going to get that wound to heal. And I think it's just a miracle. If any of us, if I make the bold assumption that we're all well nourished, and I'm sure breakfast will be coming soon, the hot breakfast, so you'll be even better nourished, but if you make the assumption that we're all well nourished, if we get a wound, it's incredible how well it heals and how quickly it heals with good nutrition. It's just, you don't even necessarily need to think about it. Or even, post-surgery, if you're well nourished, your surgical wound will heal. But without adequate nutrition, you're going to get delayed wound healing, or the wounds just do not heal. The larger the wound, the greater the demand for nutrients. And obviously if you have damaged skin and damaged tissue, and of course when we're talking chronic wounds, it's usually much deeper than just skin depth, you're going to need additional nutrients to heal that. So I had a look at some of the best practice guidelines for all sort of wound management, and this was a paper published in Wounds just back in 2017, and it was an expert panel of 11 wound care specialists, and they tasked them with reviewing the literature for specific types of wounds, surgical, venous pressure ulcers, diabetic ulcers, pressure injuries, and got them to come up with their recommendations, and then had a consensus. And I really just skipped through it to see what focus there was on nutrition from the experts when you're looking at wound management. And it came up over and over and over again. So the nutrition was mentioned as a risk factor for venous leg ulcers. Now, I guess it's a slightly different population to when we're talking pressure injuries in older people, and you've got excess weight is very closely related to venous leg ulcers. But nutrition's a risk factor, it's a factor in pressure injury development. Nutrition should be part of a comprehensive assessment, and so including blood tests like albumin, hemoglobin, iron, vitamin levels. Malnutrition in surgical wounds is a concern, and they stated that optimal nutrition is a key component in all phases of wound healing, and that nutritional support should be discussed with the patient. So it's nice for us to think about nutrition and understand that it's important, but patients really need to understand it as well. And you know, sometimes it may be the one thing that they actually can control and manage and help with in the process of healing their wound. So you should also be just talking about nutrition with the patients. So what are the nutrients that are relevant here? Well, the whole diet's relevant, but calories, so your energy intake, fluid, whether it's a nutrient or not, but fluid's obviously really important. Protein, vitamins A, vitamin C, vitamin E, zinc, and arginine. So we'll just have a look at those. So calories are really important because if you don't have enough energy, you'll start breaking down your own protein to heal that wound. So you need adequate calories, and so you need to be getting that from not just protein, but fat and carbohydrate as well, so that you can use the protein for tissue restoration. So you're preserving your lean body mass, you need it for collagen synthesis. And it's suggested, and we don't really know what the actual requirements are for these nutrients for wound healing, but most of the literature suggests around about 35 calories per kilogram for energy in wound healing. Now 35 calories per kilo, if you think of a 60 kilogram woman, that's 2,100 calories. That's a lot for an older person to try and eat. They're really going to be struggling to get that amount of calories in. So we need to think about how we can boost those up a little bit. Fluids, obviously really important for hydration. Protein, as I said, you lose that protein in the exudate, and I said that the protein requirements in an older adult, 1 to 1.2 grams per kilo. If you've got someone with a wound, it can go up to 1.5 grams per kilo. In burns, you're probably going up to 2 grams or more per kilo. So really a substantial increase if you've got a wound compared with what the recommendation is without a wound. And as I've pretty much said, for repair of tissue, collagen synthesis, and there are specific amino acids that are required. And then the vitamin A, C and E, antioxidants, which are important for development of new blood vessels and collagen formation. And zinc is a cofactor in any protein synthesis. So if you're deficient in zinc, then you're going to have trouble making new tissue. So that's really important. Zinc's a bit tricky though, because unless there's a deficiency, the evidence for a lot of supplementation is quite weak, and it's hard to measure zinc levels though. So it's a bit tricky. So this is where, when you've got all these micronutrients that are important, you need to have a look at the overall diet. So I just want to spend a little bit of time talking about arginine. Is anyone familiar with arginine at all? Heard of it? Yep, great. And are you familiar with Arginaid products? Yep, okay. So forgive me, all right, I'll just go back to what it is. So it's an amino acid, and it's called conditionally essential. So we have amino acids that are essential, amino acids that are non-essential. The non-essential ones means that our body can make them from other amino acids. We don't actually need them in the diet. So arginine is usually non-essential, but in times of stress, we can't make enough of it. The demands exceed what we can synthesize. So in a stressful time is classically something like wounds. If you've got wounds and you're needing all of that protein to make new tissue, then your body can't keep up with the arginine demands. It's the same in critical illness. We see the same issue. So you need extra arginine. It can be difficult to consume enough from the diet, and I'll show you the sort of food contents a bit later. And so arginine-containing nutritional supplements have been shown to improve the rate of healing in patients with pressure ulcers, but the arginine mode of action is the same in any sort of wound healing. So its roles, obviously it's required for protein synthesis, so it's the most nitrogen-rich amino acid there is, so it's a really important source of good quality protein. It's a precursor of nitric oxide. So nitric oxide is a vasodilator, and so if you're going to get vasodilation, you're getting better blood flow, so you're getting flow of oxygen and nutrients to the wound to help with healing. It contributes to the formation of new blood vessels and also involved in the immune system, so in T cell growth and replication. Part of collagen production, and good collagen production is important for the strength of the wound. So if you don't have good collagen production, then the wound will break down and then you're going to have this issue of a chronic wound. The normal diet, 5 grams a day is probably quite high. The normal diet is probably closer to around about 4 grams per day that we get just from our protein sources. So I'm just going to spend a few minutes talking about some of the clinical papers that have studied arginate as a product, and that's the arginine-containing oral nutrition supplement. And these studies were all done at the Austin Hospital in Melbourne, in Victoria. Nestle didn't actually sponsor these studies at all. They use arginate as part of their protocol for wound management. So the first one was, and they're all reasonably small patient numbers. The first one was 16 inpatients who had pressure injuries, and they divided them into 3 groups. They had one group just on their standard hospital diet. They had one group on a standard diet plus 2 high-energy, high-protein supplements, oral nutrition supplements a day. And then they had the third group on the standard diet plus this product, Arginate Extra. And this is an oral nutrition supplement that doesn't contain fat. It's just protein and carbohydrate enriched with arginine, zinc, vitamin C, vitamin E. And it has some other micronutrients as well. They studied the patients for 3 weeks, and their outcomes that they were looking at was their push score, so the healing of the pressure injury. And they found over the 3 weeks that the group C, who had the Arginate Extra, had a 2.5 times faster healing rate than the other groups. And you can see here on this graph, the bottom line is group C, who had Arginate in there with their diets, compared with, so sometimes it's thought that, well, if you just provide enough protein, that will be sufficient. You don't actually need anything more than that. But you can see the blue line in the middle, that's the ones that had the energy and protein supplement without arginine. And whilst it was faster than the standard care group, arginine was a lot faster. So in patients who were randomly allocated to one of these 3 groups, the ones with arginine were healing faster. They then have a second study, and they have a big community, a big spinal unit at the Austin Hospital in Melbourne. So they had 18 patients who were in the community, spinal patients who had pressure injuries. They were well nourished, and they provided them with 2 sachets of arginate per day until they achieve full wound healing. So the difference with this product, Arginate, is that it's sachets, it's just arginine, vitamin C, vitamin E. So it's only 25 calories per sachet, so it doesn't have all the extra carbohydrate or additional protein. So they didn't randomise them to, oh, you'll get arginate or you won't, because it's their standard practice to use arginate. They compared them with historical matched controls. So they looked at their records and found patients that were matched for wound, gender, age, etc. And they also looked at the literature and had a look at, well, how long would you expect a stage 2 pressure injury take to heal? How long would you expect a stage 3 according to the literature? They found that the compliance was good, and again, they had full wound healing at 10.5 weeks compared with 21 weeks for the historical controls. And this is actually not against the controls, this is against the wound healing time. So you can see that the red bars are the intervention group and the blue bars are what the literature says you would expect to see. So you can see that, so for stage 2 ulcers, the literature says that they will take around 14 weeks. That's what you would expect healing time. But in the intervention group, they took just over 5 weeks to heal. And then, so a third study, again, spinal injury patients, but these were inpatients, again with the Arginate Extra, and they prescribed Arginate Extra to all of these 34 patients, but some were non-compliant and stopped taking it after a short period of time. So they just compared the ones who were non-compliant with the ones who were compliant to have a look in differences in wound healing. The majority of these patients, again, were well nourished. So again, they've got this is the supplemented group, and that's the ones that ceased the product earlier, and the black bars are the expected healing time. So again, the supplemented group, significantly faster healing time, very similar to the other 2 studies, 6.5 weeks for a stage 3 pressure injury, just over 11 weeks for a stage 4 pressure injury. And so, you know, obviously this is what we would call real-world evidence. We're just looking at what they actually do in practice and have a look at the results. So then the group were interested in, well, we give them 2 a day, that's our standard. What happens if we give 1 a day? Like, is there a dose dependence? Is there a threshold? And so they then had a look at inpatients, again with pressure injuries, 3 weeks of standard hospital diet with 1 versus 2 arginate a day. And 1 arginate provides 4.5 grams of arginine. And as I said, the usual diet provides probably 4 grams roughly. Hospital diet might provide a bit less than that. Or 2 products a day will give you 9 grams. Random allocation, and again, used historical data as the comparator. And wound healing, again, assessed as push scores. So you can see here that actually from their results, looking at the whole group, 1 or 2 resulted in similar healing rates. So 8.7 weeks for the 1 dose a day, 8.4 weeks for 2 doses a day. So slightly different, but not significant. But if you divide them up, if you have a look a bit more closely at the data, and about half of them were malnourished and half of them were well nourished. So if you look at the malnourished group as opposed to the well-nourished group, you can see that there was actually a difference. There was a trend towards better healing with the higher dose in the malnourished group. So whether that means that we can sort of identify which patients are going to respond better, and they all respond well, but maybe some respond better, to 2 a day versus the well-nourished group was quite similar results, whether they had 1 or 2 a day. So most of the studies that we have use 2 products a day. That's all of the evidence is based on that. But now there's some emerging evidence that maybe we can play around with that dose. So that's what the data says, and that's the graphs. What about the case study? So lovely, we've got the pictures in just before the hot meal comes in, but you guys love the pictures anyway, so it doesn't bother you. So just some case studies, and this is actually from, oh no, the food's coming now, from people that we have been working with that our sales team talked to, and they have just provided these case studies when they've used Arginate. So the first one is actually a lady who was being cared for at home, potentially may not have, should not have been. She was a 91-year-old with dementia, bedbound, admitted to hospital with this stage 3 sacral pressure ulcer, which was very nasty. She started on a comprehensive wound management plan, and it's important to remember that nutrition's vital but nutrition's not going to manage it on its own either. So we're talking about nutrition as part of the overall best practice management of wounds. So this lady was started on 2 of the Arginate Extra products per day, as I said, comprehensive management plan, and after 2 weeks the wound size had decreased by 1/3. And then you can see here at week 6, the bottom picture, it's really well on its way to healing. So really, really amazing results. And the product was well tolerated by the patient. This is actually a gentleman who was living in the community, younger, 43-year-old, morbidly obese, had this wound for 2 years with so much exudate that dressings did not contain the exudate, so he couldn't work. And obviously this is just, life-changing in terms of quality of life. It's just terrible. He had small areas of necrosis in his wound. He was given, obviously, again, comprehensive management plan, dressings, antibiotics, and was also started on the Arginate sachets. Now, I don't know the full details of this gentleman's diet, but he was seen by a dietitian for a weight-reducing diet at the same time. And this is sometimes people can be concerned about, what do? You've got someone who's massively overweight that makes care for the wound very difficult. Do you put them on a restrictive diet, which potentially is going to impact their nutrition? But I think the message is if obesity or the excess weight is really getting in the way, oh my God, that looks delicious, getting in the way of your wound management, then protein is really key. So put someone on a low energy diet, try and clean up their diet. There's potentially lots of empty calories that are going in that you can change, but really try and maintain the protein intake in their diet. So anyway, this gentleman was assessed by the dietitian, put on a weight loss diet, and was also supplemented with 2 sachets of Arginate per day, which, as I said, is only 25 calories per serve. So it's not contributing to his total energy intake. He lost weight over the next 6 weeks, lost a lot of weight, continued with the Arginate, and his wound had virtually healed in that time, and he was actually able to go back to work. So really, really life-changing. And I think, wounds are just such a horrific thing for people to have to deal with, no matter what age. It's just, I can't even imagine what it must be like to live with a chronic wound. So multidisciplinary approach is really required. I'm just making sure everyone's actually tucking in, that's good, but you haven't got any food, so you can't tuck in. So just to look at where arginine is in the diet, you can see that meat serves, obviously, it's part of protein, it's an amino acid, so you're going to get the best quantities from chicken, steak, fish. Dairy is quite low in arginine, so it's not a great source. Your non-meat sources are tofu, legumes. But you can see here they're not really, really high in arginine. If we're saying that you get 4 grams a day, 4 grams of arginine a day usually, but when we're supplementing, we're going up to, if we add 9 grams, you're going up to 12 grams, 13 grams of arginine a day. That's going to be difficult, particularly if you've got someone who's older, who has a poor appetite, to get that from protein foods. Because the other thing with older people, they often start dropping their protein foods, chewing, swallowing, meat becomes a bit harder, it's more expensive, and so you can actually see that there's a decline because of their food choices, not necessarily because they don't want to eat those foods. And arginine is not necessarily that stable when it's cooked either. So I'm not really rushing through just so I can get to breakfast, but we will be finishing early. So what can you do for nutrition and wound healing? So the first thing you can do is identify poor nutrition. So if we're talking about older people, and I just want to sort of focus there a little bit, but obviously similar themes for everyone. But if we're talking about older people, it's very hard to identify poor nutrition just by looking at someone. If they're looking really skinny, then they're probably definitely malnourished, unless they've been that weight their whole life. Because let's face it, older people usually dress up to go to the doctor or leave the house. They can cover the fact that they're actually quite wasted by their clothes and makeup. And, you know, if I think about my mother, she would definitely be looking her best to go to the GP. And so you can't, it's like saying I can diagnose your blood pressure just by looking at you sitting there. You can't do that. Nutrition takes more than that. So we need to identify it. Then that will give you pointers on how much more deeply you need to go into reviewing their diet, and then consider whether supplements might play a role in meeting someone's nutritional requirements. So this is one example of a screening tool. Has anyone seen this before? Yay, for you over there. This is called the Mini Nutritional Assessment. And it's a screening tool that's been a validated screening tool that's been developed specifically for older people. And so it comes up with an actual score. And a few years ago, I was doing a PhD study, and we tried to use this, or we did use this as part of the 75 plus health assessment in a small GP practice down in Peninsula Way. And the nurses there had previously had some questions in their 75 plus health checks, but they didn't really give you any advice on what to do. So they were good questions, but you didn't really know, do I do any action? And then there's no sort of follow-up because you don't have a benchmark. The nice thing about the M&A is that it's really short. You can see that those questions are things that you probably hardly have to ask a patient because you'd probably know just from talking to them. So it's about food intake declining, weight loss, mobility, psychological stress or acute disease, and neurological problems. And it uses body mass index, but if someone can't be weighed, you can actually use a calf circumference as a proxy. So you don't actually have to have a weight to come up with a score. And it gives you a score. So if someone has a score of 12 points or more, they're well nourished, that's great. If they have 8 to 11 points, that means that they're at risk. And that means that you can probably do some simple things just to make sure that they don't continue down that slide of poor nutrition. If you've got a score of 0 to 7 points, that indicates malnutrition, and that really needs to be flagged with the GP to see whether there's anything going on that's causing significant weight loss. Because even though a lot of people do check weights of older patients, it's not necessarily done that routinely always. And it may be that they actually need a referral to a dietitian to have a closer look at their diet. So does anyone here do any kind of nutrition screening of their patients? Yeah, you do? Do you use that? Or yeah, great. And how do you find it?
Great. We actually picked up 5 cases of scurvy over an 18-month period.
Wow. God, that's amazing. Yeah. And so do you do it just when would you use it? On everyone, or when they're 75 plus health check? Right. Oh, okay, sorry. So over here, and where are you from? Sorry. In Queensland. So they use the mini nutritional assessment as part of their 75 plus health check, and they've picked up 5 cases of scurvy over the past 18 months by having a look at people's diet. So as part of, and with wounds as well, they use this as the screening tool. So this is actually available. Do you have it in your records, or, sorry, I'll repeat what. The sheet, okay. So there's a website, www.mna-elderly, but if you just look for MNA, Google it, you'll find it. And they have user guides, they have online versions of it. When we did it with the group that we did with Victoria, we got it put into their record so that it became part of their health assessment that they did online. But there are also just tear-off sheets. But the thing is that once you've got a score, you can actually have a look at it. So if you're doing annual health checks, you can see if someone's declining or improving. So then if they're well nourished and they're going along fine, that's good. But if you pick up nutritional risk, then you want to have a look a bit more closely at their diet. So, and it's just things like, how's the appetite, are they missing meals, just questions about how do they feel like eating, particularly if someone's got a wound, potentially they've also got pain and they might just be feeling unwell, so they're not going to be eating all the time. Are they able to also, might have someone who's been living independently or living on their own, but then with the development of wound and they're not feeling well, they're not feeling like getting the food, so they might have changed their food preparation. Are they able to actually go out and shop, prepare food, and review dietary restrictions? A lot of older people stick to their diets. Diabetic diets are classic, that they might have been put on 50 years ago, their portion diet, and they still won't have more than half a banana or cut the crusts off the bread, that sort of thing. So dietary restrictions in older people tend to be associated with nutritional risk more than improving whatever the underlying condition is. Yeah? Hold that thought, I'll get back to it. I've got it specifically here. So the dietary modifications, it might be things as easy as just smaller frequent meals, not having someone expect that they're going to sit down to a big main meal at whenever they usually have that, at their lunch or evening meal. Tell them it's okay to have a smaller, lighter meal 3 times a day. And definitely try and get a protein source at every meal and at every snack. And they might require assistance with shopping and meal preparation. So 10 tips for better nutrition. As I said, liberalise the patient's diet, try and get rid of any dietary restrictions. Again, I don't want to put my mother under the bus all the time, but I think about 30 years ago she had high cholesterol and she asked me what to do, and I suggested one of the margarines with the polyols or the esters or whatever they were in them at those times. To this day, she still has the Heart Smart milk, the low-fat milk, and the margarine in her fridge. I say, Mum, 88, wouldn't worry too much about your cholesterol so much now, but no, these things stick there. Encourage use of flavour enhancers if they're just not enjoying food as much. As I said, small, frequent, nourishing meals and snacks, because often if you talk about snacks, someone might say, yeah, I have a snack, and they cut a piece off the cake, the block cake, or they have a sweet biscuit. It might be delicious, but it's really not providing them with anything much in the way of nutrition. Food texture is really important. Older people might be faced with changes in chewing or swallowing capability. If they're losing weight, dentures might not fit so well anymore, and they might be able to swallow all right, but they've just started changing the texture of foods. So it might be something really easy as suggesting, tuna mornay or those sorts of foods rather than a steak. If there's a specific nutrient deficiency identified, obviously use a specific supplement for that. Reminder notes, recruiting family support, and referral to an accredited practicing dietitian if required. Now again, in this study we did with the GP practice, we came up with this really simple sheet just to hand out to their patients if they came up as being at nutritional risk. And it was just sort of simple steps, and it was 3 small meals and 3 snacks. Use full cream, full fat dairy products, don't worry about low fat ones. Pointing out what the protein foods are that can be included. Eggs are brilliant. What some suggestions of nourishing meals and snacks might include. Even a soup that if you buy barbecue chicken and you chop up some of the pre-cooked chicken and put that in there so that you're boosting up the protein in a tin soup, or a custard, puddings, milkshakes, eggs, baked beans, peanut butter on a toast is going to be better in terms of protein than Vegemite. And your question about frozen meals, I think they're brilliant now. There are so many to choose from. Some of them are great. They're probably salty is probably the worst thing about them, but they've moved so far from just the limited variety that you used to be able to get. There's some great ones now, and there's some. And of course, with the protein fad, they all pushed protein as part of them. So you can get a decent amount of protein from some of these frozen meals. So if people are looking at some easy ideas, then they're fantastic. I found, so part of my studies was also, we did some qualitative interviews with older people about their nutrition, and there's still a hesitance to use some of those foods. They're not necessarily seen as fresh in their minds. But I think just the convenience, and sometimes it might just be giving someone permission to use them, because if you've got someone who's used to cooking for many, many years, they kind of feel like they're taking the cheats way out, and that's not what's okay. So just reassuring them that they are quite nutritionally good, and that they can replace a meal, and if it means that they're going to have something other than a piece of toast, then they're definitely better. So then, if you've gone through all of these sorts of things and someone's really just not eating or continuing to lose weight, then you probably do need to look and see whether a supplement might help them, an oral nutrition supplement, so rather than just a vitamin supplement. So I guess Sustagen is probably the easiest one to access for people because it's in pharmacies. And if you do have someone with poor food intake, it's quite hard. So you can fortify meals by adding some cheese or adding some chicken, as I mentioned, or boosting them up. But if someone's just having a piece of toast, it's quite hard to fortify that with extra calories. So something like Sustagen, you can get a neutral variety, so you can actually just put a scoop in porridge, you can put a scoop in soup, you can put a scoop in mashed potato. You can just add it through the day rather than having a complete milk drink. And if you can get 2 or 3 scoops in, that's the equivalent of having the entire milk drink, and that's an extra 13 grams of protein that they're getting over the day. Then you've got your wound-specific supplements, which I've mentioned, Arginate or Arginate Extra, for chronic wounds or where you can see that healing is just not progressing. Just on the Arginate, if you have any patients who are DVA card holders, gold, white or orange, and they have pressure injuries, then they can actually access Arginate or Arginate Extra. For a month's supply is on one script, and they can get 5 repeats on RPBS, and they will pay the script fee of $6.40. So if you do have any DVA patients who fall into that category and have pressure injuries, then they are eligible to access the product under RPBS. If you're interested in hearing more about these specific products, then please come and see our team at the Nestlé Health Science stand here at the conference. We have a number of resources. This is a little sample pack which has some sachets in it. This is some just information, not specifically about arginine or arginate, but general nutrition information. One is designed for healthcare professionals and one is designed for patients. We have recipes so that for the arginate sachets come in orange and lemon flavours. The orange flavour is very much like, if anyone remembers, Tang. Yeah, that's what it's like. There's some recipes though if people want it not just as a drink. So just finally, to sum up, nutrition has to be included as first-line therapy in management of wounds. You cannot have that much tissue repair going on without good nutrition if you want to achieve wound healing. Your demands are greater when there's a wound to be healed, in particular protein, vitamin C, vitamin E, zinc and arginine. Arginate's a nutritional drink that I've shown you promotes wound healing, and really improving wound healing can only improve quality of life, so it's absolutely crucial. So good luck to all of you in helping your patients achieve good wound healing, and thank you very much for your attention.
Thank you,
Probably got
Jean.
time for any questions.
Yeah, we've got time for some questions. So we're not due down in the plenary until 8:30. So you've got a little bit of time if you do have any questions.
Are you going to take the microphone, or
Yeah,
because they can't hear?
I'll give you that. Say thank you.
Oh my God, a low protein snack. I'm an Adelaide girl, so Hagues is definitely, I'm all over Hagues. I think there was a question there.
Good morning. Thank you for your presentation. I'm just wondering if there are contraindications to the use of arginate interactions, high protein diets for some people. Thanks.
Yeah, so on arginate, the arginate extra, the main contraindication is for someone with renal disease, because it's not the protein so much as the phosphorus. It's quite high in phosphorus, so not so much there. At the Austin Hospital, they do use arginate powder for their renal patients, but they may sometimes just use the one a day because they're actually, sometimes vitamin C, they're just a little concerned about vitamin C, but they haven't ever seen any issues. And we don't have any reports. I mean, essentially the doses are not that high in any of them to be of a concern. So we don't see any issues with anyone else. The question about protein, the high protein diets, and often this comes up with older people concerned about renal function and if we're encouraging protein. The most recent consensus paper about protein requirements for older adults, they specifically had a nephrologist on it because this is a concern often. And really, if someone has renal function, that's okay. The sorts of protein levels we're talking about are not going to compromise their kidney function. And in fact now, low protein diets for kidney function are really not used anymore. It's pretty much the RDI. So no, there's not an issue. And if someone actually has renal failure, they're being monitored so closely that you can see if anything goes astray. But that's the main thing. Arginate extra, not for renal patients. In fact, Sustagen, not for renal patients either, because again, phosphorus. On here.
Could you just go through the prescription information again? I was a bit confused. It sounded like it was just for DVA people.
It is.
So you can't. So a non-DVA person can't
purchase
get it.
But they can purchase it. Like they can go to their pharmacy, but the pharmacy most likely will need to order it in. And so it is only on a script for DVA because to try and get PBS is very difficult. Yeah.
Just wondered what the cost is.
Yeah, I knew someone was going to. Yeah, it's $56 for one box, and if you're using 2 a day, that's 1 week's supply. So the issue is, and that's obviously an out-of-pocket expense for people. We do find, obviously, that sometimes relatives are willing to pay anything if you've got this chronic wound that is not healing and you're halving the time. Dressings are incredibly, as you know, incredibly expensive. So I guess we make that decision, but it's offering it to patients, and I think dietitians, I know we tend to make an assumption or a judgment about what people are willing to pay for, and we might be dealing with them harshly. But yes, it's expensive. Yeah, Patricia, our marketing manager's probably got more to offer than I have on the cost of it.
Yeah, I mean, I think the cost is a very important aspect, but I suppose one thing that I've been in nutrition for not a long time now, but one thing I've often noticed is people do see supplements as a cost. I see it more as an investment. Because by halving the time required for wound repair, you're actually reducing the costs associated with managing that wound anyway. So if you consider a sachet is around $4, you compare that to the bandaging, the time associated with bandaging, potentially your additional time required with helping that individual get wound healing, and just the general sort of impact on their quality of life. Loss of activity, all sorts of things play into it. So I would consider it, and when we've talked about it to a broader array of healthcare professionals, when you switch it on its head to say, well, yes, it's a cost, but what is it offsetting? Is it an investment in improving the time and reducing the time by half? I mean, that's the clinical evidence. It halves the time required for wound repair. So if you look at it from that perspective, I think families, individuals, carers, I think they're much more receptive to the idea that, and I'm not talking just about arginate, just nutrition in general, like just investing in what's required to equip you to better deal with healthcare conditions. That's just a general message at all, regardless of whether it's arginate or anything else. Sorry, just on the stand, we do have some flyers that you can provide to. We are working very hard to try and have this available in pharmacies on a broad array, but we also have flyers on the stand that you can provide to patients that look at ordering from one of our preferred distributors, and they actually have slightly better pricing than you would get for the $56 as well. So feel free to come and see me on stand.
There's another one.
Thanks, Rebecca. I'm Sonia. I'm from Melbourne. Have you got any larger randomised control trials around Arginate and Arginate Plus?
Not arginate, but there are about arginine-containing
Arginine,
supplements
okay.
from overseas, primarily not in a community setting, primarily in a residential aged care setting.
Do you know how large those trials are?
There are...
Not off the top of
testing
the
me
head.
now. So, well, there are a number, but there's enough evidence that there are systematic reviews and some meta-analyses have been put together. So they obviously are bigger. I think the biggest would be a couple of hundred patients. But again, as I said, most of those, and to put them together for a systematic review, they will obviously need to be the same sort of patient type to get enough data. And they are predominantly pressure injuries in a residential aged care setting. Similar results, yeah. The doses, as nutrition studies are always so hard to pull together because outcomes are always a bit different, nutrition's always a bit different, the products are always a bit different, but a disease-specific supplement, I think the consensus of the literature, a disease-specific supplement does seem to enhance wound healing, yeah. No? Done.
Sounds good. I think you're all able to head over to the plenary session now if you want to. Get in your seat early, otherwise we're all done here for this morning.
Go and get a
Thank you,
coffee.
guys.
Thanks, everyone.